they diagnosed that the person had epididymitis. And when this person came to me, the person actually had a torsion of the testicular torsion. So that's why I was inspired to do this slide so that I help someone out there that if you have a challenge you're having in diagnosing these two, you can easily have other options of evaluating that this person has a torsion or not a torsion. So I think we can go to the next slide. My name is Muhangi Micah. I'm a medical imaging technologist from Uganda. We can go to the next slide. So we can just start with the scrotal anatomy, which is it's composed of the skin, the subcutaneous tissues, the medium rough, which is separating the two hemiscrotum, the left and the right. Every male has two, at least the right and the left testis, but we call them the right and left hemiscrotum because it has all those other components, the vas deferens, the epididymis. So that is how we look at the normal anatomy. And the normal anatomy, whenever we are doing maybe like the technique, we're going to use a high frequency probe, most preferably the linear probe. The linear probe is usually, because why do we use it? Because it's clear when we are viewing superficial structures. And the scrotum being that they're outside, then this becomes very important to use a linear probe when we are doing these scans. However, we can also use the curvilinear probe for some testis because of the depth. For example, and sometimes if we have like infections, like a foreign gangrene, like if you have an abscess or the scrotum are having infection and
sorry,
pus.
Mr. Muhangi.
Yes.
We're still on the first page.
Yes, we I'm moving on. I'm now on the third slide, but we can go to the second slide.
Yes, you're on the third slide, but the slides here are still showing first on the introductory part.
Mr. David, can you move the slides for us, please?
Yes, but as he's doing that, I could be just going through so that we don't take so much time and we can just always go back to the slides and I just show you the particular maybe text. So if we look at where I'd stopped, I was saying that we could use also the linear, the curvilinear in case, like I've met a case where this person used to have multiple sexual partners and then because of the infections he got, the scrotum was infected and then it started rotting. So that's what we call a foreign gangrene. So there's a lot of air, there's a lot of abscess formation. So you need a curvilinear probe and the testes are always swollen. So that's where also the curvilinear comes in to help the linear probe because the linear will not get to those much depth good for superficial viewing, not the other.
Mr. Muhangi, when you want me to move the slide, just say next, because I'm changing the slides from my side. Next. So you should just say next and then I move it.
Yes, just move to the next.
Testicular torsion.
Yes, next. You're going to slide number 2.
No, like I've moved, like this is not even number 2. This,
you already
normal anatomy was 1. Second slide is on scrotal ultrasound technique.
Your screen is still showing the first slide, Mr. David.
Yes.
I think there could be a problem because I'm changing the slides from this side. So I don't know why it's doing that.
Okay, now it has moved. It has changed the slides.
Yeah, there might be a problem because I'm actually changing the slides as he's
presentation mode. On your right, on your line, yes.
You wanted me to change what?
To presentation mode. On your right, on your lower right, before the zoom, there's a button there which shows only one slide at a time, and you just press to go to the next.
Which one?
Lower, on your right lower side, before you go to the zoom, there's a button there before the zoom.
So
before.
I actually, no,
No.
the things that from...
No, on the side before, on your left before the zoom. The first button on your left before the zoom.
So
on the right lower.
So what you are saying is not exactly what, you're not seeing my screen. So you might say before the zoom, but so let me just put it into the slideshow.
Okay.
Can you see the technique now?
We are seeing the technique, but it's not on the full screen.
Yeah,
Want it to be full?
No, it's full screen from my side. Yes.
How are you?
Good, how are you?
I'm okay, thank you. I think you can enable first of all, enable editing.
Okay, let me just stop sharing and then I repeat share screen. Can you see my screen?
Yes, sure.
Yes. Enable editing.
Enable editing first.
Enable editing.
Yes.
Then you put it on slideshow.
So radiographers are being taught presentation skills. It's a good skill to acquire.
Is it full screen?
Yes,
Yes.
now it's full.
On technique.
So we can first the first
Thank you so much.
slide. You can go back first. Go back. The first slide, the second slide. Just go back one slide. Yes. Yes. So that's what I was talking about. The normal scrotal anatomy. I talked about the skin, the muscles, the connective tissue, covering both the testis and the epididymis. So, but we can go. The blood flow is what I wanted to highlight actually. That the testes are supplied by the differential. The testicular artery supplies the testis, and then the differential cremasteric pudendal arteries, they supply the vas deferens, the paratesticular tissues, and then the scrotal wall, the skin and whatever, and the median raphe and everything. But the venous drainage is by the pampiniform plexus, which is, if it's dilated, if those vessels are usually dilated, their parameters, we could talk of varicoceles, scrotal varicoceles. That is one thing we need to note about that, apart from on this page. Maybe something else we need to note is the red testis. The red testis, these are tubular structures in the mediastinum of the testis, or in the middle part, to put it in layman's language, of the testis. So sometimes you might think they are pathological, but they're not pathology. It's just normal. It's a normal finding that when they are a bit dilated, it's a normal finding. We call it the red testis, or the media. They are found at the mediastinum of the testis. We can go to the next stage so that I show them the red testis. So where you see that arrow, that is what we call the red testis. It's in the mediastinum of the testis. You might find that, and maybe you're thinking maybe this person has an infection or something. No, this is normal scrotal anatomy. And also to note on that image, there's some free fluid in the corner there. I don't know if everyone can see it. So that free fluid in the corner is normal. The normal scrotal anatomy is supposed to have some free fluid around the testis. Some little, it should not exceed 1 centimeter. So 1 centimeter, that means we are going to have pathology like a hydrocele, in form of a hydrocele, because hydrocele is water, the hydro, and then the cele is to represent that in the corner there. As you see, there's a small arrow there. That is normal free fluid, which is we expect in the testis. Yes, there, as they have showed it. So the scrotal skin should also be measured, because you can have edema of the skin, which can be in form of cellulitis and also other conditions. So as you're also trying to look at the ultrasound technique, we also need to measure the scrotal skin. I've already talked about the probes we are supposed to use. But another thing we need to note is the penis is usually lifted superolaterally, that you put it on the patient's body, or you tell the patient to hold their penis, or you can just push it up and then put a towel over it so that it doesn't dangle in your field of vision. So when the patient is lying supine, the testes are going to also be in that same format. We are going to see the reason why I'm talking about that lie of the testis. So we can go to the next sketch. The next slide. So this is something which I'm talking about, that the normal testicular echo pattern and color flow Doppler. The testis is supposed to have little flow, just like you're seeing those on your right, the little flow, you know, the little blue and the little red. The red is representing arterial flow. The blue is representing venous flow, which is back. So echo pattern, we usually try to compare both testes. That's why you see on that left image, on the left sonogram, we have put two testes, and you see that the echogenicity is roughly comparable. It's homogeneous, it's not heterogeneous. It's homogeneously, at least you can see on those two. At least that is what you should also try to incorporate in yourself as you're trying to do a scrotal scan, that you try to compare both sides, how this side and this side. The testis is just like an eye scan. If you're doing a B scan, you have to compare both the eyes, that this side and then the other side, because they have to be the same. That is in reality, they have to be the same, because these are two organs which are similar, just like the kidneys, they are two and they have to be the same. If one changes, that means there's a problem with that side. So we can go to the next slide. So I can introduce you to the scrotal pathologies. You're going to find, we're going to classify them into three: infectious, traumatic, and vesicular. If we talk about infectious conditions, these are conditions which are brought about by disease pathogens. For example, epididymitis, epididymo-orchitis, biocil, foreign gangrene, which I've told you, which is when the testis starts to rot. Usually, actually, it involves also the penis, and usually the remedy or how people treat it is they cut off the penis. I have seen this happen to someone. There's also abscess. Those are infectious conditions. Then we can have another one where we talk about the traumatic. The traumatic ones are like herniations, for example, those people who work doing heavy stuff, heavy lifting. Usually they can get herniations, inguinal-scrotal herniations. You can have hydrocele, hematomas, all these ones, like for example, someone is going to play football and then he's hit by a ball. All these ones usually present to the emergency department, and they come with some of these conditions like hydrocele, hematomas, and you can easily see them on scrotal ultrasound. It's one of the surest ways to diagnose what is inside when the doctor is not actually able to see what is inside. We can also have vesicular conditions, which include the torsion, which we're going to talk about today. We can have an infarction, which is usually comes later after a testicular torsion if it's not managed. We could also have scrotal varicoceles under the vesicular conditions, because that is the irritation of the pampiniform plexus. So those are three major categories we are going to classify. However, today, what we want to discuss is the infectious, which is confusing itself as the vesicular. Testicular torsion versus epididymo-orchitis. So I think we can go to the next slide. But it's very important that as you as a sonographer, as you as a medical imaging technologist, as you as a radiographer, it's important that you play in a team, like you work together, you get all the information before doing some of these scans, because clinical history guides you a lot on what to expect. So for a testicular torsion, this is, as I told you, it's a result of the twisting of the testis and the spermatic cord within the scrotum. Like this, the testis turns around the spermatic cord, and there's twisting of that cord. So the blood flow is compromised. That's why we're putting it under the vesicular conditions. So there's going to be, first of all, occlusion of venous return. And then also the supply is also compromised, because remember the arteries are still within that cord. So if there's twisting, usually it can be 360, can be 480, can be 720 degrees. So that depends on whatever the clinicians decide. So, or what they find whenever they do the surgeries. So we can talk of the testicular torsion, which occurs more on the right than the left. It occurs more on the left, sorry, than the right. And the reason being given, and from my research, usually the left spermatic cord is longer than the right, which is also the case usually with the scrotal varicoces. They always give you about the renal arteries. So something is related. They always has to connect with something in the abdomen. So the treatment of the testicular torsion is a true urological emergency. And what I meant in this is we should not delay, because this is an emergency case. Salvage of the testis usually is 6 hours to 12 hours. So if you do not diagnose a patient right and that time surpasses, this patient is going to have likely infection. Infection is going to make them be infertile. And when they remove this testis, they're going to remain with maybe a single testis. Usually they can put maybe a dummy testis there, which does not contribute really to their beauty, because you are having just dummies down there. So it is something that we have to really help our clients, us as the sonographers, by doing something which is good, by doing our job of diagnosing, but diagnosing right. Because if you also say there's a torsion and then the surgeon goes there and really there is nothing, then you've done this patient a disservice. In my case, which inspired this, someone diagnosed a different, that this is an infection, but when we went there, I did the scan. It's just a repeat scan, which someone just ordered out of, because now this this patient, when they diagnosed that the patient has testicular torsion, they referred the patient to another facility where I work. I happen to work with the professor of urology, and this professor of urology told me we need to repeat this scan because what I'm getting clinically doesn't correspond with what the sonography of this other person did. So we need to up our game. That's why we provide you with this knowledge, and I'm happy with the Radiology Without Borders for giving opportunity to people to learn, because I've been in most of these sessions and I really get something from them. So the diagnosis is usually based on the absence of intratesticular blood flow, which this person just saw, which sometimes you can see or not see. Sometimes there is reduced flow. Sometimes you can have a torsion, but when you have normal flow, that's why I said that the twist contributes a lot to how much of the torsion you have. If you have 360, you're not going to be like the same person as the one who has 720. So the one with 360 might have a little flow, which someone will consider normal, and they pass and they're like, no, this is also fine. So we need to have a diagnosis about that torsion. We can go to the next slide. The next slide is talking about the clinical evaluation. So this is what I think my professor used, and he's like, hey, but what is not happening? So usually we use the twist scoring system, which is which can help us to. This system was developed some years back. So usually they give a grade that when you find a hard testis, you're going to give a score of 2. If you find a swelling, you're going to give a score of 2. If this person is having nausea and is also vomiting, you're going to give a score of 1. If you have an absent cremasteric reflex, which I'm going to show you in the next slide, in the next coming slides, you give a score of 1. If you have a high riding testis, you give a score of 1. So if a person scores very high on this score, maybe like they have a hard testis, they have swollen testis, they are nauseated or they are vomiting, they have an absent cremasteric reflex, high riding, this person can be taken straight out to surgery, because you don't need really a scan. Because the more time you save is the more you're going to find these testis when they're still viable. Okay, so we can go to the next slide. However, those who have lower scores, you can take them to the scan so that they really look at them, and this person will scan. Since they are looking inside, they'll tell you what actually is being seen. So this is a picture of a high riding testicle on the part B. You can see that the testis is a little bit high. So that's what we call a high riding testicle. It's also a hallmark of testicular torsion. Clinically, because there's shortening of the cord, since this testis has already turned inside, as you can see on part A, when it has turned and it's in 360, that means it's going to shorten. Something which was long shortened because it has twisted. So there's another sort of a coil. And that's what I call the real pull sign, that twisting. And that is one of the hallmarks of testicular torsion. However, as you can see on image A on the left, the normal testicular portion, the normal testis lie according to that you can see how it's lying. But you see that in testicular torsion, the position has changed. It has become abnormal. Like it's now no longer horizontal. Is it horizontal? Okay, it's no longer vertical. Should I even call it vertical? Okay, that position you're seeing on the left of image A, it has now changed to an oblique line. You can see it's horizontal, more of horizontal or oblique in the testis. So that is also one of the hallmarks of testicular torsion, that the testis is going to change in position. So it's very important that you take note of some of this. You pay attention that because the testicular torsion will not present with all the sides, but you need to have at least some that you're going to look at and you're like, no, this is testicular torsion. So we can go to the next slide. So we have the sonographic findings of a testicular torsion. I based more on testicular torsion because this is an emergency case. So I wanted us to really understand it in broad and to expand our knowledge and our technique. So usually we can look at the testicular volume because one of the things that are going to help you is comparing both sides. You're going to find that in testicular torsion, the volume is going to increase, that the other side, usually the testis is like 5 by 2 by 3. You're going to find that when you're comparing the other side and this side, one side is going to be increased in volume, or it's going to even change in shape. Some research studies have talked about that the testicle is going to become globular in shape. Globular, what do I mean by globular? Globular, that means it's like an egg, like something very round, not the normal testis, which is usually, as you can see in the upper image, which you're seeing up there. Yes, so that it becomes a bit globular in shape, like a bit more rounded, which can show you that maybe here you suspect torsion, but that's not what you're going to base on only. You have to base on multiple things. You can also look at the testicular position. Usually, as I told you, they're in that upright or vertical position. So remember this person is lying supine. So they expect to be in that same format, like they are lying paralaterally to the thigh. But if you find that instead of lying paralaterally to the thigh, they have now become they're at an angle to the thigh. That means they have now changed position. So now testicular torsion, that's one of the other things that happens, that the position is going to change. It's not going to be upright. Now it's going to change the axis and it's going to become maybe horizontal or oblique to the long axis of the thigh or the femur. Then you can suspect torsion. Then you can also look at something else, which I said the whirlpool sign, which is the abrupt course or the twisting of the spermatic cord. So you'll find that maybe I'm going to give also the next image. You look at this whirlpool sign. But the Bermuda Triangle, actually, I said it. It's like the way you see if you flush water to go down a toilet, it will move in circles, going down a small hole. So that's what we call a real pool sign. The spermatic cord, after twisting, it becomes more of like a spiral twist. So this is more of a specific sign. There are two specific signs here, which I'm going to talk about. This real pull sign, which is the spermatic cord twisting against itself, and then the epididymo cord complex, which is shown in the image, which is you see below there, that this cord is going to twist around the epididymis. The epididymis will become enlarged, and you cannot differentiate between the epididymis and the cord itself. So whenever you put color flow here, you'll find it's increased, but the epididymis will not have flow. Remember, because the cord has twisted around it, that means the flow is going to be compromised with the epididymis. The epididymis might become heterogeneously hyperechoic, and the cord will become a bit heterogeneous also. So that's what we call an epididymal cord complex. So it is the conglomerate of an edematous epididymis. As I've told you, the edematous epididymis is due to the twisting of the cord around it. And then also because the torsion has tied a knot around the epididymis, so it becomes enlarged, and that is what I'm talking about as an epididymal cord complex. So you can also talk about that in your scan reports, because usually sometimes actually someone can miss this one because they talk of a pseudomass in the scrotum. It's important to note that that pseudomass is what we call an epididymal cord complex, something you can read more about. I put some text at the end of the slides so that someone can do some research on some of these other things. We can first go back to the next slide, the last slide, because I'm trying to go through one of the other features that will occur in epididymis, epididymo-orchitis, epididymitis, and testicular torsion is reactive hydrocele and thickening of the scrotal wall. Or you see it in all these cases, and you see I've talked about it. Then there's altered blood flow. So altered blood flow, that means this where we are being taught in our class that you find whenever in testicular torsion, there'll be no flow. That is true, but it's only true if you're having a complete torsion. But if you're having an intermittent torsion, like a torsion which the testes undergo torsion and torsion by themselves, then this is not going to be true because you have preserved flow. As I've told you, those which are having 360, you might find the flow is normal. Then those which are at 720, which you cannot grade you yourself as a sonographer, but they can do this in theater, and they will know that this person is having maybe a torsion at 360, a torsion at 720. So it's important that we look at these signs that I've talked about. We can go to the next slide. So the next slide, I talk about the testicular position. I give some cases, which are three. One of it was a 6 years, 4 months boy. No, this was a 4 months boy with a first episode of acute left scrotal pain for 2 days. So you can see the normal testicle in A, the upper image. That is no change in the testicular axial position. Then torsion of the testicle on the other side, you can see that the orientation of the testis has become now, it's a bit inclined, it's a bit oblique. I don't know if you're noticing that on the right. That is the first image, the first two images. So the next image was for an 8 years, no, it's a 3 months old boy with, sorry about the years, no. So with the third episode of acute left scrotal pain for 5 days. So all these were pediatric cases, initially misdiagnosed as epididymitis, as I've told you. Usually, the most people will diagnose epididymitis and not torsion. So it's important to look at the position. You see the normal position, the testis is lying in the axial position, in the axial direction. You can see it's lying straight. But you see in the second image on the right that the position has already changed. So this is one of the hallmarks of testicular torsion. You see there is an inclination. So as I told you, we don't only base on this, there are also other factors to look at. However, here I'm just looking at the testicular position in relation to testicular torsion. I wanted you to have a visual of what you see. So the third case is a pediatric still of 16-year-old boy with right testicular pain. And we give you some sonogram of the images. You can see that the testis, actually this one is clear, that you see that the testis has been inclined against the other one. The direction has changed. You see it has become larger. There's hydrocele. Like, it's just clear that this is a torsion. Can go to the next slide. Next slide. So this is what I was saying, that the Bermuda Triangle is one of the classical examples of a ripple, according to me, because we had a lot of myths that planes which move around the Bermuda Triangle, they go inside, they disappear. So I wanted to bring it here so that people try to remember, some of the things when you bring pictures and examples outside class, someone understands better. So the Bermuda Triangle is something of that image. Sailors used to, whenever you come near it, you usually, it takes you inside, but you can see that it's a spiral twist of maybe like water or something. That's why I also use an example of a toilet, that whenever you flush, the water moves in circles, concentric circles, until it disappears inside there. So this is what I'm talking about, okay? So the number of twists determines the severity of vascular impairment. That is something to also note, that I've been talking about, that sometimes you might see normal flow, but when the testis has tossed. So usually we give a 4 to 8 hour window before ischemic changes start to occur and long-term effects now start to happen. We can go to the next slide. The next slide. So I gave a case presentation here, but basically I wanted you to look at that, still that real pool sign, that you see the twists, the black against the white is like the other Bermuda Triangle that I've just showed you. This was a case of a 16-year-old male who was a pediatric with a history of retractile testis, struck his scrotum against the bathtub. These are also one of the clinical presentations, that this person will have a history of maybe acute pain, which is not the case for epididymo-orchitis. Epididymo-orchitis, someone will have pain for more than some days, but orchitis, usually the pain starts and it's severe and it's just for a few hours. So he arrived at the primary care clinic the next day with acute right scrotal testicular discomfort and nausea. That's also one of the clinical signs that I gave you. 2 hours, you look at the time, it is short after the pain started. Upon physical examination, the right scrotum was sensitive and elevated. You look at a high riding testicle. That's also still is pointing you could be having a torsion. So when you're doing a scan, you're already having something in your mind, you're building something. Okay, this could be this. It's important that as you scan, you already know what your end goal is. You have an idea, what am I looking for? What should I rule out first? So already you have some history guiding you. That's why it's important that you coordinate with the clinicians to get the proper history, and so that you're also able to help them find the right maybe answer to their clinical questions. So when they did sonography, it revealed a swirl of the spermatic cord known as the whirlpool sign, which you can see there. You can see the twists, the black, and then the white. You see like they are concentric circles. So this one, it was a torsion of 2 turns. Yes, thank you. So we can go to the next slide. So this case presentation, actually I just wanted to show you the whirlpool sign. So you can still see the other slide on the left. You can see that it's a whirlpool sign. And on the right, on the left, till I described to you, I show you the tunica vaginalis, which is the blue. You can see it on the outside. Yes. And then the yellow is the testis. Yes, that is a testis. And then the spermatic cord, which is green, which is there. And those are the concentric circles that I said. It's important to note that the tunica vaginalis covers the testis. So any scrotal pathology which occurs inside there is a part of that scrotal pathology. So we can go to the next slide. Yes, actually, so this patient underwent surgery, and you can see that the 2 testes are there. So these are some of the effects that we don't want the patient to reach, because they did manual detorsion, again it went back, so until they did surgery. So this patient, that is how the testis looked like after surgical exploration. So they are mildly enlarged and congested right testicle. Okay, you can see that there is also a difference between the 2 testicles. So this is what we call yes, you can see the color is different. One is that one is viable, the other one is not viable. So yes, that one is enlarged and then it's also not viable. So we can go to the next slide. So this is what I talked about, the cremasteric reflex. The cremasteric reflex, a clinician taps on the side of the thigh, the medial thigh of the male, and whenever they tap, there's supposed to be an elevation of a slight elevation of the testicles going up. So that's the cremasteric reflex. In a normal person, it's there. So if it's absent, then yes. So here I talk about epididymitis first, which is the inflammation of the epididymis with or without infection. That is very important because some people might think that epididymitis occurs with only infection. No, epididymitis can occur even without infection. However, some of the causes of the epididymitis include pathogens like chlamydia, like gonorrhea, and then coliform bacteria. So you might see that some of these ones are sexually transmitted infections, and then the coliform bacteria can also be gotten from the normal flora in our body. Like you can see these homosexuals. It's a hot topic in Uganda, banning homosexuals, what. When you engage in those homosexual bacteria, in those homosexual behaviors, these are some of the things that are going to enter your system, and then through blood and also the location, these infections are going to move down to the epididymis, and the epididymoid is going to be more affected, and then it's also going to infect the rest of the epididymis, and you will develop epididymitis. So it's important that these people, the homosexuals, these are also some of the factors to stop them, some diseases they can get from such behaviors, because it's not a natural way of life for Africans anyway. For Bazungu, I'm not sure. Maybe they have been doing this for a long time, so it becomes normal. So these infections, some of the infections, I've told you some of the disease pathogens that might cause that. However, we can also have the one which doesn't have infections, which can be due to acute pain, which can be due to trauma. And once there's trauma, then there's going to be there's going to be some inflammation of that epididymis, and then you have you develop epididymitis. So the cremasteric reflex, I've told you that you release it by stroking the skin of the upper medial thigh, which should always be evaluated, and it will be positive in this case. Then another clinical sign, which is very key for epididymitis, is the relief of pain with the elevation of the testis, which is the Prem sign. The Prem sign was developed by the person, is called Prem, till in, I think in the 1800s. So he developed this specific sign because he noticed that in epididymis, whenever he would strike the person, whenever they would lift the testis, there was a relief, like this feeling of, at last, like the pain doesn't feel so much as before. However, with torsion, even if you do this, you still feel pain. So that's one difference. It's important for us to know this clinical knowledge, because actually some of the reasons why the radiologists are better than us is because they have some of this clinical knowledge that you can correlate with to improve your diagnosis. So we can go to the next slide. So the sonographic signs, of course, one is going to be enlargement of the epididymis. There's going to be reduced heterogeneity of the epididymis, and have increased vascularity on colorful Doppler application, and have skin thickening, and then reactive hydrocele. Most of these I don't want to talk about a lot because most of you have encountered. Like on the right, the second image, you can see that there is hypoechogenicity, or a speckled appearance. So the speckled appearance is due to dilatation of those epididymal tubules. So it's more of hypoechoic and thickened. I'd put in measurements for the epididymis, but I don't know, I'm not seeing them. But the head must not measure more than 1.2 centimeters. The body must not measure more than 0.4 centimeters, and the tail must not measure more than 0.5 centimeters. So for that, up there, you can see that there's increased flow of the right epididymis. So this is confirmatory of the blood flow is confirmatory of the epididymitis. Can go to the next slide. Yes, the next slide is all about ochitis, which is the inflammation of the testicle, either unilaterally or bilaterally, usually caused by viruses like mumps or bacteria like the gonorrhea, Escherichia coli, the Klebsiella pneumoniae, all those organisms, the bacterial infections usually that happen with the prostate and the urinary tract, they can also cause the bacteria. So it's usually in young patients, as I told you, like mumps, those are viral, and rubella can bring in still the ochitis. So the patient presentation, usually the patient will present with acute onset of testicular pain, but might involve one testicle or might spread to the other. So they also have fever, they also have malaise, and then there is fatigue and chills, because remember, this is an infection. So that means they're going to present with high fevers, chills, and fatigue. So the pathophysiology, the inflammation of the testis and isolated acute ochitis is a very rare phenomenon. Like you can't have only an infection of the testis. Usually it's very rare. So the infection usually spreads from the epididymis to the testis. So it's very rare that you have only one of them infected. As you can see with the disease-causing organisms, they are the same with the epididymitis. So it's important that there's that blood-borne dissemination from the epididymis to the testis. So, and then viruses are also pathogens that cause that ochitis. Like I told you, mumps and rubella. The next slide. So this is what the image I got on the right, that when you put a Doppler, you'll find the Inferno Sign. The Inferno Sign, for those who have done thyroid scans, you get a thyroid. That is where the term was coerced, the Inferno Sign, because there's a lot of flow, and that is classical of thyroiditis. However, when doing my research and also in my practice, I've seen that actually most of these terms in ultrasound, they're made by us. And as long as the person, you're able to describe that there is an Inferno Sign, I'll get straight out the thyroid. That, okay, if you've seen an Inferno Sign, that means there's high flow in the testis. Then I would start relating that there's high flow or hyperemia, the testis. Then there's going to be enlargement of the testis, as I described. Then there's going to be heterogeneous echo pattern of the testis. Remember, in the epididymis, it's hyperechoic. The testis, it's heterogeneous. Okay, and in normal testis, they're going to be isoechoic or homogeneous. So it's important that you compare the testis, both sides, the flow on this other side, the flow on the other side. You notice the one which has increased. You notice the one which has increased in blood flow. You notice the one which has increased in size. You notice the echo pattern. One is different. You notice scrotal skin thickening, which is also cellulitis. You can also notice a reactive hydrocele, which I told you, fluid in the testis more than 1 centimeter. And go to the next slide. So in my learning points, as I get done with the slides, that we need to differentiate, first of all, between torsion and epididymo-orchitis. Okay, one sign that I've given you that is a hallmark of ochitis is the Inferno Sign. And then the hallmark of torsion, we have two. We have the epididymo-cord complex, where I said that there's a pseudomass in the testis, in the hemiscrotum, that is formed by the twisting of the cord around the epididymi. So that is the epididymo-cord complex. And then we also have the real pole sign, which is the twisting of the spermatic cord in the hemiscrotum or in the inguinal ring, depending, you'll see, as I've already showed you earlier. So it's important that we look at some of these things. And then also, the blood flow does not exclude, if you have normal preserved flow, it does not exclude that a person doesn't have torsion. You need to go ahead and look at other parameters so that you don't miss the diagnosis of a torsion, because this is an emergency case. The ochitis and the epididymitis is just a medical case where a person can be given antibiotics and then the next day they are fine. But a torsion, we need to do surgery, and it's important that the time frame where we can salvage the testis is observed. Okay, we can go to the next slide. Okay, so we're going to question and answer. Do you have some questions for me? The presenter, if the people have some questions for me before I go ahead, I want to fire them my own questions from what we have discussed.
I think fire them, then they'll fire you.
Yeah. All right, we can go to the next slide. So question number one is a patient has a positive Prem sign. Which diagnosis below is most likely? So one, we can have bacterial vaginosis. Two, we could have acute epididymitis. C, we could have testicular torsion. Or D, we could have a PID. So maybe someone can give me an answer to that. There are just few questions.
Okay, so either people can raise their hands or you can put your answers in the chat. Let's all be interactive. No answer is wrong. We can all participate in the chat if you cannot raise your hand.
Yes, people can put in the answers in the chat and we move forward. From what we have been...
I would go with acute epididymitis.
Oh, okay. So we can go to the answer, but the gentleman is correct. One thing I said, the hallmark, a clinical sign is the Prem sign is for acute epididymitis. The elevation of the testis leads to relaxing of the pain. Like the pain does not become that much, reduces somehow. However, this is not permanent, that whenever you do that, the pain will go away for days. No, you have to go and seek medication, then the person. So it was discovered by a gentleman called Douglas T. Prem, who lived in that time, and he published this sign in the Journal of Urology. As I've told you, sometimes this case is handled by urologists. Actually, not sometimes, but all times. However, also general surgeons can handle, but it's by urologists. That's why this was published in the Journal of Urology. And we should always push ourselves that the only way, actually, I've always been talking with Dr. Bwanga from Zambia, that some of these things, touch is going to be as photographers. You see, this person published in this journal a long time ago, and we still remember. So the only way we can push our association, the only way we can push our profession as sonographers, is to publish our work and to do research. So we can go to the next question. So question number 2. Hey, you've gone ahead. Giving people an answer. Okay, below is a longitudinal color ultrasound Doppler image of a 31-year-old with acute left scrotal pain and recent diagnosis of chlamydia trachomatis, even differential diagnosis and the reason for the diagnosis. The sonogram, you can see it there. I've already given you an answer because you've seen the answer, so I think we can be quick with this one. I only have 4 questions. So the answer here was Epididymo-orchitis. Why? It's because you're seeing that image. You can go there. You can first go back to the image. No, go back to the image. The other image. Yes, you can see that there's hyperemia. Like there's a lot of flow on that epididymal head and also in the scrotum, which I'm seeing involving also the epididymal. So this is a case of orchitis. As I've told you, it's rare that you have only orchitis. So usually involving both the penis and the testis. That's why I'm calling it Epididymo-orchitis. Okay? Yes, most of the cases, like 90%, patients who had orchitis also had epididymitis. All right, we can go to the next question, question 3. Yes, question 3. This is the 46-year-old with left scrotal pain and pelvic pain. Those are two words to underline: left scrotal pain and pelvic pain, with hyperemia of the epididymal head and the spermatic cord. Another thing to highlight: there is hyperemia of both the epididymal head and the spermatic cord as it traverses the inguinal canal. And you can see that I've clearly put the arrows. One, the sonogram of the vas, image E, you can see that the sonogram of the vas deferens. I've talked about the vas deferens in the normal scrotal anatomy. So the same patient shows enlarged and was inflamed. The left was inflamed, the right was okay. So the patient's symptoms resolved after treatment with ciprofloxacin. So what is the best diagnosis for this case? The patient is having both scrotal pain and pelvic pain with hyperemia of both the epididymal head and the spermatic cord. What is the best diagnosis to this case? And you can give me an answer. Someone to give me an answer? I put this case here for a reason, because we have been doing this, and when you look at these images, and it's quick to really make a diagnosis, because I failed to get the videos to put them in here. Anyone? Anyone? Anyone?
There's Doris who has unmuted his mic or your mic.
Yes? Yes, I see some answers in the chat. Okay. Any answers? Any more answers? Present because I wanted to test how you have been able to the slides. Here is quick to say this is about the epididymis being inflamed. But remember, another key thing I've added is the vas deferens. The vas deferens. The vas deferens, these are vesicular conditions. So this is a case of acute vascitis. This infection usually presents and is combined with acute epididymitis. Just like I told you, ochitis is rare alone. It will be combined with epididymitis. So the same with vascitis. It will be combined with acute epididymitis. However, it's an inflammation of the vas deferens. Usually this infection spreads in the pelvic organs. Remember, that's why this patient, I told you to underline. One is you're having both scrotal and pelvic pain. So this pain is coming from, is sort of like referred pain from the testis into the pelvic region. So that's why I talk about this. There is another term which someone has put in my inbox, funiculitis. That is an inflammation of the cord, which is not so relating to this. This one I was in particular to the vas deferens. However, we can have an inflammation of the cord, which we call that the funiculitis. That will be a topic for another day to discuss. I usually want us to break down to these small units so that we understand these things and we can go and practice them in our day-to-day life. However, if we give you too much information, like I'd come and discuss testicular torsion, I came and discuss scrotal abscess, foreign gangrene, all those other cases, maybe herniation, people are not going to learn. But if we discuss small, then we're going to get more out of this. Remember, we have very many days in a year. So we can always do this and learn about the scrotum, about everything. And we have something we can take from a particular presentation. So the sonographic findings for acute vascitis, of the scrotal segment, you'll have heterogeneously hypoechoic appearance of the vas deferens. Then the vas deferens will be thickened and given with the diameters 0.64 centimeters or 6.4 millimeters in diameter. Then color flow is going to increase. There's going to be increased blood flow, or there's also associated inflammation, as you can see from the other image. First, go back to question 3. So you can see that E, the normal, which is the right, you can see it's appearing normal, but this other one has increased flow. This was at the level of the inguinal canal, so that is what I'm talking about. So usually it occurs with inflammation of the epididymis, and you can see on your left image that the epididymis is this other one with arrows, and then the other side also the vas deferens are the ones which are having increased flow. Okay, we can go to the next slide. Question number 4. Just to challenge you, this 12-year-old boy who woke up with acute left testicular pain and experienced nausea and vomiting along with pain. So why I'm giving you this clinical information, because it's tapping into your brain that you try to remember the clinical signs and the hallmarks of testicular torsion. So maybe someone can give us the best. Already someone has sent to me already. This is a testicular torsion. We don't need to waste a lot of time, but you can see what I'm trying to describe, that there is a sort of a ring of fire, sort of a real pool sign, that is sort of coiling of tissue. I don't know if you're seeing that. So you can go the answer, maybe. Yes, you can see the classical real pool sign, the spermatic cord. So this was a case of a testicular torsion. You can look at both testes and they appear normal. But when you look at the spermatic cord, it's the one which is twisted in concentric circles, as I've told you. You can also call it a ring of fire, but still not so much, because ring of fire would be sort of just one. We would prefer to use the real pool sign. You can use any words as long as that sign can be interpreted by someone who is a professional. Because most of the things that doctor is going to look at down there is the conclusion. However, us as sonographers, we shall go to your report in the body and we look at what you described. I look at some people saying maybe this person is having pyelonephritis, but you said the kidney is appearing normal, both in shape, size, and echo pattern. Where have you gotten the pyelonephritis from? So it's important that whatever you're describing up there correlates with what actually you have in your conclusion. Most of these clinicians won't understand these terms. You're going to bombard them with, except the specialists who have been seeing these scans over and over again, and they know the terms that you guys are using. Okay, so we can go to the next slide. So these are some ways that I put that we can improve our sonography skills. One is be confident. As you're doing this scan, you're not the first to do the scan, and you're not going to be the last. These things are learnable. Have confidence. Whenever you're confident, you're going to make the correct diagnosis. But if you're in a panic, if you are not confident about the scan, you're not confident about the knowledge you have, then you're going to be in a state of panic. And whatever you'll be seeing will be scaring you. Whatever you'll be seeing, you're not relate anatomically. But these things, whenever you relax, you're confident, you know, okay, this is my testis, this is my epididymis. Go step by step if possible. Just be confident. As long as you can tell what is abnormal from normal, you're somewhere, you'll get there. So the other thing is, I'm saying, take your time. No one is rushing you. Even professors, I always see internal medicine specialists. After this patient going to so many hospitals, they send them to an internal medicine specialist to maybe look at them. And you prescribe small medication. Why? And the patient gets fine. Because it's important that you take your time to understand the nitty-gritties, because that is where the diagnosis is lying. Because you're going to treat the patient. So you need to treat them as a whole. You need to all the things, or you need to do these scans, go to the epididymis, scan the testes, look at the scrotal skin, look at the median raphe, look at any hydrocele. Are there any herniations? Then another thing, you need to know what you're looking for. That's why I highlight that you need to have the clinical history, the presentation. Don't just come because they have called you for a scan, straight away. You're finished. My friend, you need to know what you're looking for. Now that you've been given enough clinical history, you've noticed the patient has a positive Prem sign, then you know maybe I'm looking at epididymitis. But if you find there again scrotal micro calcifications, don't be surprised, because pathology doesn't read books. These things are all possible. So you need to know also the normal anatomy. That's why we do a lot of the normal, so that you can differentiate the abnormal. What we were taught in school is to know the normal, so that when you meet abnormal, you know that this is abnormal and you can comment about it. It's important because it also helps you to becoming a better sonographer. So you need to follow up on the patient. Whenever you work on some of these complex cases, follow up what happened in surgery, what did the doctors find. It boosts your confidence, first of all, in yourself and also in your skills, and also gives the doctors that, okay, this person is practicing evidence-based medicine. No one is an island. You can't be knowing it all. Even me, myself, there are some areas where you take me and I will not know anything. And I'll say, I'm here to learn. What do you see? Then practice makes perfect. Sonography, just like radiography, is the practical skill. If you don't practice, trust me, you're going to forget these things. If you take 2 years, you'll be an expert now, but after 2 years, my friend, when you get a probe, things will have changed, diagnosis would have changed, like a lot will have changed, and you won't be able to diagnose the torsion. Trust me on that. This is a practical course. And that's why I like it. It was very practical. So that was my parting shot. I thank everyone for listening in. And those are my references. In case of any questions, you can fire them at me. And thank you very much for the opportunity to present on this platform. I'm currently waiting for any questions. If